Ok, entonces
Hello
I'm gonna
everyone. Hello everyone. Welcome to our Zoom meeting. Today we're gonna discuss different topics. So, Dr. Mayra, when you are ready, you can use it to
perfect.
share.
I'm gonna share my screen. Hello everybody, my name is Mayra and I'm gonna be yeah. Let's go put this one. Do you guys all see my screen? Perfect. Okay, the topic that I'm gonna discuss today, first of all, my name is Mayra Mezzoni. I'm a MD from Venezuela and I'm part of the Lyme group. And today we're gonna speak about Contra Library and how to search in PubMed. Let me just put this tiny. Well, Contra Library is a collection of databases that provide high quality, independent evidence to support decision-making in healthcare. This library is really important because, as you know, like pharmaceutical industry, they try to push so many of the medications, so many of the data that we read and qualify because of they are the ones that that have the clinical research, have the investigations, have all this money. But this is they always have a monetary advantage in it. So these libraries really interesting because they're independent, they're free, and they do not accept or work with anything related with pharmaceutical connection. So it is really like not biased medical scientific library. So as you say, you can view content for all the main databases by using any of the search options for the Contra library. It is a free online resource that provides an introduction to health evidence and how to use it to make informed health choices. And it's designed for healthcare consumers, policy makers, and members on the healthcare team. Then this library was created as a systematic review. His main objective is for systematic reviews. And it was created on 1993. His location and his the first person that created was in the United Kingdom, and now it's a global network of researchers and content reviewers. Are one of the most highly regarded sources for healthcare evidence. This part of the content library contains systemic reviews and carried out by the content review groups. Each group focuses on a specific healthcare topic and conducts systemic review in this area. And there are different ways that you can use this library that I'm gonna work you through a little bit on the homepage of how to use it. Control Central Register of Control Trials that they call Central. It is a database of randomized and randomized controlled trials. The records come from a variety of published and unpublished sources, like including PubMed, Medline, Embase, CINAH, clinical trials from the government, and on the World Health Organization, all international clinical trials registration platforms. Then, just a second. Oh, I'm sorry. Confirm clinical answers is something really important because sometimes you just need to find something really specific, like how do I give the doses digoxin for this patient? They have these clinical answers that is like shortcuts. These are short answers to clinical questions to support point of care decision making using digested evidence from the relevant content reviews. And they include, like, for example, graphics, they include data and links to other sources to support your quick research. Now I'm gonna share with you guys. Contours is divided into 3 tabs. You can choose to search from conducting basics or advanced search. You can choose medical terms, MESH. That's the way they call it, to search current content using MESH terms. Or you can search for manager for creating complex search strategies. Now I'm gonna pass you guys to the video. Let me just This is how it looked like. Do you guys still seeing my screen, no? This is how the control library looks like. For the search, you can go to the search or advanced search if you want to, and then you can go by terminology and you can apply for search. I would like to play a video of how to use it because it is like
اطلع البس عشان الساعه 12 ونص هنطلع.
I'm sorry.
خليها بترد ليها هذيك.
Well, I'm gonna put on the chat. I'm gonna put a link for a video that I found of one of the many videos that I watched of how to use this it was one of the best, and this one I'm gonna play it because I think it's like the best video, and it's just 2 minutes. And you guys let me know if you hear my sound. If no, I can put the link on the video in the chat.
Sorry, Dr. Mayra, I cannot hear the sound.
Oh, you guys cannot? Well, do not worry. This is a 2 minute video. I'm gonna put I'm gonna put the link, copy the link in the chat, and you can guys watch it, and it walks you through how to do the search, how to do the advanced search, how to do the medical terms. Because I don't know how to figure out how to like share the sound, but it's in the internet, and for all the videos that I searched, this one was the most self-explanatory of them. Now I'm gonna go back to my presentation, and here is the link. I will copy and paste it after I finish. And now we're gonna speak about PubMed. As you know, PubMed, we all have tried to use PubMed, and we use
can you unshare and then share, or switch the screen? We're still on the video screen.
Can I? Let me see.
You can just unshare the screen on the phone.
Can I?
The screen. Or the tab, where is it?
How I do it, Dr. Nadine?
You are presenting from PowerPoint, right?
Yes, it is a PowerPoint, but I have the video on YouTube.
Yeah, so if you unshare your screen and then share your screen and then point your...
Okay, let me unshare my screen, pause sharing, and then new share. Did you guys hear it? Did you guys hear it now?
Yeah.
Perfect.
Sorry about that. You can share again.
Oh, did you see it?
Mayra, can you share the screen again? Dr. Mayra,
Yes.
you can share your screen again. Sorry.
Oh, okay. Let me try to. I'm going to the menu. Oh, just 1 second. Okay. Okay. That I know. Yeah. You guys hear it?
Yes.
Great.
We didn't hear, but we saw the video. Maya, before you start sharing the video, you can choose to share the audio also, because we didn't hear anything.
Well, I know that some of you were not able to hear it, but let's go back.
Yes, you can restart share the content, but before you share it,
Okay, thank you for the next time. Don't worry, I will share the link and you guys can read it, but at least you saw how the page works, where to apply the things. It is really friendly. I think PubMed sometimes is more challenging than the Cochrane library. And in that way, in that sense, I think it's really easy to use and it's really really helpful. Just now we're gonna speak a little bit about PubMed. I know that many of us have used it, and it's one of our main tools to use when we're trying to, for example, for us that we're trying to apply a systemic review or to collect our data. But if you don't know how to do it, or if you don't have techniques of how to search in PubMed, it's going to be a little bit overwhelming in a lot. So these are some of the techniques that we can use to search in PubMed. As we know, PubMed comprises more than 33 million of citations for biomedical literature from medicine, life science journals, online books. Citation may include links of full text content from PubMed central publishing web. And this is how it looks when you enter it. The basic search for PubMed is really easy. You enter the term in the search box, and then you're gonna find millions of articles or citations. But PubMed may suggest topics for you, and if you would like any of them, you can simply click one of these, and it usually is a good idea to start and to narrow your result. One of the important thing is that PubMed is not like Google or anything of all the search that we use, that you cannot use full sentence. You have to use keywords. That's really important in this part. You have to use keywords, author, names, identification, put my identification numbers to begin your search. It is a really good guideline from Harvard University that I'm gonna put the reference in the chat. And I'm gonna, as well, I'm not gonna play the video of the one that I found because it's too long, but I'm gonna give you the links. It teaches you what are the techniques to search in PubMed. One of the most important techniques to search in PubMed is advanced search. In advanced search allows you to narrow your search and find specific resources. You select in advance under the search bar, and then you can view your search. In here, you're gonna add terms to the query box, and then you're gonna apply do not limit to title, author, journals, and match the pair information of files descriptions. Then other form of search, there are many techniques. And these techniques, okay. These techniques, you can apply it for any other pages that you use, and they work really well in PubMed, including Boolean operators, truncations, and search filters. Boolean operators are used to connect pieces of information with a search. You can use the operators and, or, and not to focus your search results. Here I'm gonna do some examples. And use the narrow to search. All terms connected must be present in the result. For example, virus and cell death and influenza. That is gonna search any information related to these topics. If you want to use, or if you wanted to broaden your search, you use the term or. Use the either of the terms must be present in the results, like flu or influenza. So this is gonna give you tons of millions of papers and citations and books and from them. If you want to exclude, you use the word not. That will ignore terms that maybe typically be present in your search, like viruses, not influenza. Then you're gonna have the whole tons of viruses. So this is a good Booleans or operators are really good to narrow, to broaden, or to exclude terms in your search. Truncation. Truncation is really useful for PubMed because when you apply the asterisk, it builds on the asterisk keyword from the right. So it broadens, so it expands your search. Search multiple variations of the word, like singular, plurals, or conjugations of the words. For example, this word like gene. Entonces, it's not only gonna look for the word gene in papers, it's gonna look for genetics, genetically, genomics, etc., etc., etc. Entonces, this broaden your search. Then we have, as we know, one of the ways to organize our search in PubMed is with the identification number. And the identification number is really peculiar for each paper. Often you may want to find particular citation in PubMed. There are a couple of quick and easy ways to do this, and you use it to the PubMed identification number. And it appears in each citation. You just simply have to find it. For example, here in the bottom, you can search it. Here in the bottom, you can search it. Sometimes we have it on the top and in the abstract below the authors, we have those numbers. This is just a really quick review of how to use these techniques. This is the video that I'm gonna paste for you guys on the chat. This is a little bit longer, it takes like 10 minutes, but it is compressed really good, and it works you through how to really use these search techniques. As I'm going back, I'm gonna stop sharing my screen. And if you guys have any questions, I'm here for answering, and I will pass the information. Thank you.
Thank you so much, Mr. Mayra.
Of course. Does anybody have any questions? I'm gonna copy and paste all the links, because these two videos that I found, they were really helpful. Really, really helpful.
Thank
Okay.
you for sharing, and it's excellent topic,
Okay.
because it's important to know about it.
Yeah, it is really, because Dr. Nadir, many of the searchers that we look of, for example, Up to Date or PubMed, they have in some way a connection with like pharmaceutical companies. This is, of course, they're gonna be pushing you to like read their knowledge or like whatever. And you need something that is not biased, and that's why Convert Library is really good and have everything you can like. And for quick answers, that mesh term is really like useful to have it. This is, I'm gonna give then my teammates, they're gonna present. I imagine Dr. Dalia and Dr. Samia are here. I hope you girls that you can start presenting. Thank you so much.
Hello. Can you hear me?
Yes, we hear you perfectly, Dr. Samia.
1 second. Can you give me just 1 second, guys? I'm trying to share my screen. I'm not sure what's going on. So hi, everyone. Thank you, Dr. Mayra. Thank you, Dr. Nadir, for giving us this opportunity. Dr. Dalia works really hard on this, and I would like to share it with you. I'm going to be presenting about prostate disease and cancer. 1 second. I'm sorry. You can give me just. Thank you, everyone, for being patient with me. Sorry for that.
Thank you. No worries.
Okay. Okay, is it clear? Can everyone see it? I'm not sure if my screen is.
Yes.
Okay. Okay, so I will be starting. Today we're gonna be presenting about prostate disease and cancer. So type of prostate disease, we're gonna talk about benign prostatic hypertrophy, prostatitis, and prostate cancer. Benign prostatic hyperplasia is also called prostatic hypertrophy and referred to an enlarged prostate gland. It's a non-cancerous, which is benign, as we refer to. Prostatitis, inflammation or infection of the prostate gland, and prostate cancer. We're going to talk about it. It's a prostate gland, and mostly it's prostatic adenocarcinoma. Okay. So prostatitis, one moment, I just need to. Okay, so sorry for that. Prostatitis, inflammation and swelling of the, which is causing pain, and in the prostate gland, it's most common type of prostate problem in people under the age of 50. There are two or like a couple of different types. So we're gonna cover acute bacterial prostatitis, which starts suddenly from bacterial infection and is treated with antibiotic. It is not that much common. When we do urine tests, there would be leukocytosis in the prostatic fluid and positive bacterial culture. There will be also systemic sign of infection, like the patient would have fever and other symptoms of systemic inflammation. For chronic bacterial prostatitis, it happens when bacterial infection keep coming. That means it's recur. It's going to be mostly long-time symptoms. Symptoms usually start slowly, and it may take longer to treat than acute bacterial prostatitis. Again, we have leukocytosis in the prostatic fluid, positive bacterial culture. Here, there is no systemic sign of infection. This is a different, there will be no fever. Non-bacterial prostatitis, usually it's, most probably it's just symptomatic, like symptoms like pain, but there is leukocytosis in prostatic fluid and negative culture. Chronic prostatitis, this is also called chronic pelvic pain syndrome. And it is the most common type of prostatitis. We're going to cover this. And asymptomatic, that means the patient have no symptoms and does not usually need any treatment. You may learn, you have it after like having tests for any other issue, and then they will have positive culture, but there is nothing, like the patient is asymptomatic or they don't show any symptoms. For etiology of prostatitis, acute bacterial prostatitis can be caused by ascending infection through the urethra or due to reflux of urine into the prostate duct, direct extension, or through lymphatic and spread also, like lymphatic spread or blood spread from the rectum. Common pathogen for acute bacterial prostatitis, gram-negative organism, E. coli, Enterobacter, Serratia, Pseudomonas, Enterococcus, and Proteus species. Rare cases can be caused by Erronemus, Hydrophilia, Acavia. These are gram-negative bacteria. These are mainly in cave diving person. So consider Neisseria gonorrhea and Chlamydia trachomatis infection. This is also common in male under 35. Increased risk in nursing home. So nursing home patient with catheter and those undergoing rectal prolapse sclerotherapy. Sorry, 1 second. So chronic bacterial prostatitis etiology is due to primary voiding dysfunction. So it's more like a structural or functional problem. But again, E. coli will be considered in 75 to 80% of cases, Enterococci and gram-negative aerobic in the rest. Other pathogen, Chlamydia trachomatis, Uroplasma, Trichomonas vaginalis, and uncommon organisms like Mycobacterium tuberculosis and fungal species are also considered causes. So associated conditions with chronic bacterial prostatitis are HIV infection, cytomegalovirus infection, and inflammatory condition, for example, like sarcoidosis. Also for chronic bacterial prostatitis, tuberculosis is one of the causes. So tuberculous prostatitis may be also seen in renal tuberculous patient. So for chronic pain or chronic pelvic pain syndrome, chronic prostatitis. So the causes are really poorly understood, may involve an infectious or inflammatory initiator. So it could be initiated by inflammation or infection, but at the end, it resulted in neurologic injury and pelvic floor dysfunction. So common site of pain, the patient can present with perineal pain, testicular pain, could be pubic pain or venereal. And urogenital pain is often more bothersome than urinary symptoms. So the main symptoms or the main presentation is pain. This is why it's referred to as chronic pelvic pain syndrome. So 25% of those patients with chronic pelvic pain syndrome have inflammatory bowel disease. These are also common, and 5 to 8% of those patients eventually will have bacterial pathogen isolated from their urine or prostatic fluid. Causes could be or may include, as we said, it's mainly functional or structural bladder pathology. So it could be vesical neck obstruction, pseudo dysnergia, or impaired detrusor contractility. Could be also ejaculatory duct obstruction or increased pelvic side wall tension, muscle spasm, and non-specific prostatic inflammation could be also a cause. Okay, so how we diagnose patient with prostatitis? To diagnose the patient, the healthcare provider will assess symptoms and perform physical examination. So from symptoms, as we said, physical examination, and then we start with digital rectal examination. We check for prostatic gland pain and swelling. Also through the digital rectal examination, we can do prostate massage to collect sample for seminal fluid analysis. Another thing is urinalysis. As we said, it depends on if it's acute or chronic. There would be leukocytosis and positive bacterial culture, so we can perform culture, also to check for urinary tract infection, and blood tests. Also, blood test mainly to measure prostate-specific antigen. You can do CBC, blood urea nitrogen, in case of complication for kidney. CBC will show like leukocytosis in case of acute infection. Prostate-specific antigen, high level may indicate prostatitis, but it could be for other reasons. Benign prostatic hyperplasia could be high on prostate cancer. So more invasive tests, we could use cystoscopy, not diagnostic, so we could look for other urinary tract problem. It does not diagnose prostatitis, but we could like rule out urinary tract, like if there is a stone in the bladder, cancer. So just to rule out other condition. Transrectal ultrasound, they could do both transabdominal, transrectal ultrasound. Transrectal ultrasound, we can use it for acute prostatitis. It would show if there is inflammation. There would like maybe thickening of the capsule and of the prostate. It would show sign of inflammation. But it does not improve. Like usually we use the ultrasound for people who does not improve, like their symptoms. They had acute bacterial prostatitis, did not respond to antibiotic, so we can use transrectal ultrasound. This test can show prostate gland abnormality. As we said, it could show you like if there is prostatic capsule thickening, it shows sign of inflammation, or if there is an abscess or stone, you could also see that, and you would be able to manage accordingly. So how we manage a patient who present with prostatitis? How are bacterial form of prostatitis managed or treated? So in acute bacterial prostatitis, antibiotic may be needed for 14 to 30 days. And we start usually with IV antibiotic in hospital if the patient is presenting with severe symptoms. And rarely we might need surgery to drain if there is an abscess on the prostate. So the choice of antibiotic is based on the result, urine culture, and sensitivity, but the initial therapy usually should be targeting gram-negative enteric bacteria. As we said, the most common is E. coli, so useful agents are fluoroquinolone, trimethoprim, sulfamethoxazole. We could use also ampicillin, gentamicin. So as we said, it depends on the results of the culture and sensitivity. And definitely in sexually active men under 35, or any patient over 35, but you are considering him or who is practicing high-risk sex, we should consider treating also or covering Neisseria gonorrhea and chlamydia trachomatis. So, as we said, in case we have an abscess, we have to do surgical drainage, and again we have to add antimicrobial therapy like clindamycin. You can add that intravenously to cover anaerobic. Medical management is often unsuccessful. However, in which case surgical drainage is required. So we have to do surgical drainage, transrectal or perineal. It could be aspiration of the abscess is preferred and is often effective, especially if the symptoms do not improve after 1 week of medical therapy. So we should start with medical therapy and go for surgical drainage. So for chronic bacterial prostatitis, it's a bit challenging to treat. You may need up to 3 months of antibiotic to sterilize, like to completely sterilize the prostate. If the prostate cannot be sterilized, in this case, we use low-dose antibiotic can be used here to prevent recurrence. Antibiotics are the most common therapy used to treat chronic bacterial prostatitis. Eradication of bacteria is associated with clinical success in the short and long term with chronic bacterial prostatitis caused by both traditional and non-traditional bacteria. So antibiotics are useful. Again, fluoroquinolone here are the mainstay in the treatment of chronic bacterial prostatitis. Fosfomycin also has been shown to have a good activity against extended spectrum beta-lactamase producing organism. We can use also azithromycin for chlamydia infection in case we're suspecting STDs, and most other antimicrobial agents are unlikely to eradicate the infection. Okay, so again, surgery is usually not indicated in case of chronic bacterial prostatitis. However, in select situation, if the patient have episode of chronic prostatitis that improve with antibiotic, but then recur again, transurethral resection. So we go for complete removal, transurethral resection of the prostate or transurethral vaporization of the prostate. This may remove needles of infection. If there is a stone, if there is any cause of infection, we can treat that. This needles may be in form prostatic stone. These stones are usually visible on transrectal ultrasonography, as we said earlier. Okay. Okay, so what about how to treat chronic pelvic pain syndrome? So prostatitis, as we said, treatment depends on the cause and the type of prostatitis. Asymptomatic, when the patient is asymptomatic, inflammatory prostatitis, we don't need to treat usually. But for chronic pelvic pain syndrome, we use something called system called U-point or A-point. We classify symptoms and then we treat according to these categories. So they say that approximately 80% of men with chronic pelvic pain syndrome improve with A-point system. The system focus on these just symptoms and you treat accordingly. So this is an example of the symptoms that you can see if the patient is presenting mainly with urinary symptoms. So the patient have urinary frequency, urgency, obstructive voiding. So in this case, we target treatment for frequency. So we can give anticholinergic, we can prescribe alpha blocker. Again, psychosocial. If it's something that because of depression, the patient having an anxiety, poor coping mechanism, catastrophizing. So in this case, we can prescribe antidepressant, amitriptyline, and we can use also counseling or refer the patient for psychologist. Organ specific. So if the patient have with gentle palpation for the prostatic, it's a very typical symptom, like we're having pain, tenderness. So in this case, we can start antibiotic course, and then we can check if there is an infection and treat according to that. Can give finasteride if it is VBH. So it depends on that. Also cholesterol. Infection, if the patient is having symptoms like recurrent UTI, bacterial localization, we have a culture, there is positive bacteria, we can prescribe antibiotic. If the patient is mainly presenting with neurologic symptoms or systemic symptoms, so pelvic neuropathic pain, or there is other associated condition like irritable bowel syndrome, or patient have fibromyalgia. So we can give, again, tricyclic antidepressant or gabapentin or gabapentinoid. And for tenderness, just or spasm, muscle spasm of the perineal pelvic floor, we can give muscle relaxant. We can also send the patient for physiotherapy, local heat therapy, Cushing. They can use the donut Cushing for sitting, and massage therapy. See, so it depends on the cause. So this is, again, the same thing we talked about in chronic pelvic syndrome. We can use, as we said, alpha blocker like tamsulosin and muscle relaxant and psychosocial therapy. Okay, we target like anxiety, depression, and for organ, it depends on the organ affected. So if it's inflamed prostate, we can also prescribe antibiotic in case of infection. And so it is the same thing in the treatment we mentioned in the table. So again, the same thing for chronic pelvic pain syndrome. Other therapy are considered to treat, and it could lead to symptomatic improvement, but have not been studied extensively in chronic pelvic or bacterial prostatitis population. So these are mainly for chronic pelvic pain syndrome. As we said, we can use physiotherapy with myofascial release and paradoxical relaxation, biofeedback, transcutaneous electrical nerve stimulation, or acupuncture. Some medication for neuropathic pain, we said we can use gabapentin, gabapentinoid, antidepressant, and psychotherapy also would work. Neuromodulation procedure, we can even go to do spinal cord or sacral nerve root stimulation, and definitely bladder training. So patient will be like, you can teach the patient to do regular voiding and completely emptying the bladder and these kind of things. Therapeutic ejaculation also would be helpful in chronic pelvic pain syndrome. Okay, so this is regarding prostatitis. Now we're gonna talk about benign prostatic hyperplasia, or as we said, we can call it also benign prostatic hypertrophy. It's histologic diagnosis, so there is a proliferation of cellular element of the prostate, and this will lead to a large prostatic gland. Chronic bladder outlet obstruction, secondary to benign prostatic hyperplasia, can cause urinary tract infection, and cause of urinary stasis, impair kidney function if there is a complete block, recurrent urinary tract infection, and gross hematuria, and it can also lead to calcular renal stone or calculi formation. So by the age of 60, about 50% of people with prostate will have some sign of benign prostatic hyperplasia. And by age 85, about 90% will have signs of the condition. So we'll have patient presenting with symptoms and sign of the benign prostatic hyperplasia. About half of all people with benign prostatic hyperplasia will develop symptoms that require treatment. So 50% of them will be symptomatic and will need treatment. Okay, so what are signs and symptoms that people with BPH or benign prostatic hyperplasia will come with? So enlargement of the prostate will cause obstruction definitely of the urinary flow. So nerve within the prostate and the bladder may also play role causing these symptoms. So it's nerve stretching, irritation, the obstructive symptoms. So the patient will come with urinary frequency, urinary urgency, nocturia, and they will describe that waking up at night more than 3 times or more than 4 times, hesitancy, which is difficulty to initiate the urinary stream, and also interrupted and weak stream, and incomplete bladder emptying, the feeling of persistent residual volume, regardless of the frequency of the urination, and straining, the patient strain or push, so Alajab maneuver to initiate and maintain urination in order to more fully empty the bladder. Decreased force of stream also, the subjective loss of force of the urinary stream over time, and the patient will also have dribbling. So loss of the small amount of urine due to poor urinary stream, as well as weak urinary stream. So the bladder will be full and the patient will have some sort of dribbling after urination. Okay, so diagnosis, so digital rectal examination also, we can use that. Digital rectal examination, integral part of the evaluation in men with presumed, if you were suspecting benign prostatic hyperplasia. So what we can assess the prostate size, the contour, and evaluate if there is a nodule, detect if there is any symptom suggestive of malignancy, or like if any nodule that may suggest malignancy. Lab study, so urinalysis, again, we will start with CBC and can do urine dipstick method and via scintigraphied sedimentation evaluation to assess for the presence of blood, leukocyte, bacteria, protein, or even blood glucose. And then we will go for urine culture Also, could be useful to exclude infection because the patient is presenting with irritation symptoms like frequency, so they could be cause for irritative voiding, and usually performed if initial urinary results and other findings indicate an abnormality. Prostate-specific antigen, although BBH does not cause prostate cancer, but men at risk for benign prostatic hyperplasia are also at risk for this disease and should be screened accordingly. So, although screening is still remain controversial, Dr. Nader put on a topic about screening. It's very helpful. Maybe if there is an opportunity for next time, I can present that also, because we'll talk about recommendation for screening. So electrolyte and blood urea nitrogen and creatinine, these evaluation are useful screening tool for chronic kidney disease. So in patient who's having high post-void residual volume. Usually it is not routine. Like we don't routinely send patients who come with symptoms for benign prostatic hyperplasia for creatinine measurement. It's not like indicated in the initial evaluation. Okay, ultrasound could be also done ultrasound abdominal, renal, transrectal. So it is useful helping determine the bladder, the prostate size, the degree of hydronephrosis in patients with urinary retention or sign of kidney insufficiency. Generally, it is not indicated for initial evaluation of uncomplicated lower urinary tract symptoms. So usually we don't send people for ultrasound. Endoscopy of lower urinary tract infection. Again, cystoscopy may be indicated in patients scheduled for invasive treatment or in whom a foreign body or malignancy is suspected. So we usually don't do cystoscopy as a routine assessment. Endoscopy may be indicated in patients with history of STDs, also like gonococcal urosaritis, or patients who have prolonged catheterization or in case of trauma. Okay. So part of the assessment of severity for benign prostatic hyperplasia, there are two systems that are being used to assess for severity. So determined by this, one of them is IBSS, which is International Prostate Symptom Score. And the other one is the American Urological Association Symptoms Index. So we use these with disease-specific quality of life also question. And then these are questionnaire the patient will answer, and there are to assess like for severity. So some of these this is like this for the frequency. The question for American Urological Association Symptoms Index, some of them are like incomplete, emptying, the patient is having that, frequency, intermittency, urgency, weak stream, straining, nocturia. There are also other tests that could be done. We can do the flow rate. This is useful in the initial assessment and can help determine patient response to treatment. Also, we can use a post-void residual volume, urine volume. This is also, we can use it to check for the severity of bladder decompensation. It can also be obtained invasively, like we can consider catheterization, or non-invasively with just using transabdominal ultrasound. Pressure flow study. Finding here may prove useful for evaluation of bladder outlet obstruction, so we can use a pressure flow, and urodynamic study to help distinguish poor bladder contraction ability. So if there is detrusor under activity for or this as a cause like for bladder outlet obstruction. Cytologic examination of the urine also, we can use urine cytology if the patient predominantly having an irritating symptom to just exclude cancer. And also infection. Okay, so management, pharmacologic treatment. So agent used in the treatment of benign prostatic hyperplasia, we can use, so usually we'll start patient on alpha-adrenergic receptor blocker, 5-alpha reductase inhibitor, which will take like need time around 6 months so you can have reduction in the size of the prostate and then improvement of symptoms. Alpha blocker will give you like quicker relief of symptoms, and we should always advise patient because of side effect of alpha blocker. Patient will have like maybe orthostatic hypotension, so we should be careful with that. And phosphodiesterase 5 enzyme inhibitor also is another form of 5-alpha reductase inhibitor, and phosphodiesterase 5 inhibitor. Anticholinergic agent also could be used. Surgery, we can use transurethral resection of the prostate, so complete resection. So there are criterion standard for relieving prostatic outlet or bladder outlet obstruction secondary to benign prostatic hyperplasia. Open prostatectomy reserved for patient with very large prostate, more than 75 grams, patient with concomitant bladder stone or bladder diverticula, and patient who cannot be positioned for transurethral surgery. Laparoscopic surgery, definitely, or robotic prostatectomy. Robotic prostatectomy is also something that we should consider. Okay. Sorry, 1 second. Not. Okay, so minimally invasive treatment, transurethral incision of the prostate. We can use also laser treatment used to vaporize or cut the prostate tissue. Multiple laser types are available, including green light, helium, and thallium. Each has its own strengths and weakness. We can also use transurethral microwave therapy, generate heat that causes cell death in the prostate, leading to prostatic contraction and volume reduction. Also, transurethral needle ablation of the prostate, high intensity ultrasonographic energy therapy, currently in the clinical trial stage. We can also use water vapor thermal therapy, rhythm, or water jet ablation therapy, equablation. Implanted device to relieve prostatic obstruction, we can use prostatic stent or urolift. And another thing we can use is prostate artery embolization that performed by a radiologist. So this technique has yet become established and standard of care therapeutic option. Okay, so we're done with prostate cancer. With prostate hyperplasia, we're gonna talk about prostate cancer. So prostate cancer represents the second most common cancer in men worldwide, and it's the fifth most common cause of cancer death in men. In the United States, it is the most common cancer in men and the second most common cancer cause of death in men. So acinar adenocarcinoma of the prostate comprise 90 to 95% of prostate cancer diagnosed, and ductal carcinoma and neuroendocrine carcinoma account for the majority of additional cases. Okay, so what are signs and symptoms that a patient with prostate cancer will present with? Most patients presenting with prostate cancer do present with screen-detected cancer and are asymptomatic. So most of them, they are presenting because of the detection of the cancers due to screening. Local symptoms associated with prostate cancer can include lower urinary tract infection or lower urinary tract symptoms, and hematuria, hematospermia, and erectile dysfunction, urinary retention. However, these symptoms are generally not caused by prostate cancer itself. So physical examination alone cannot be reliably differentiate benign prostatic hyperplasia from cancer. But there are findings in patients with advanced disease may include, so the patient would have cancer cachexia, bone tenderness, if there is metastasis to the bone, lower extremity lymphedema, or deep venous thrombosis, adenopathy, and over distended bladder due to outlet obstruction, and also neuropathy. Okay, so as we said, screening is still controversial. So there are multiple institutions, collaborative group who have addressed prostate cancer screening. One of them is the United States Prevention Service Task Force. They are recommending against prostate cancer screening in 2011, 2012. In 2018, they did reverse this recommendation to include screening after an informed discussion. So there are certain criteria for it is again due to it depends on patient preference and patient decision. So as I mentioned, Dr. Nader put on a slide about just like for prostate cancer screening, and we can maybe go through this in the next session. So imaging or diagnosis, so elevated prostate specific antigen level. So it is not a guarantee. It doesn't guarantee the absence. If we have low prostate specific antigen, that doesn't mean there is no prostate cancer, but the risk of disease increase as the prostate specific antigen level increase. So from about 8% with prostate specific antigen of less than 1 nanogram per ml to about 25% with prostate specific antigen level from 4 to 10 and over 50% level over 10. So abnormal digital rectal examination finding, this is also it depend. So it's an examiner dependent, so you might miss finding, and serial examination over time are best. So you have to be performed many times. Most patients diagnosed with prostate cancer have normal digital rectal exam results, but abnormal prostate specific antigen reading. So imaging, we can use multi-parametric MRI. It's recommended as an initial diagnostic test for suspected prostate cancer. Patients whose MRI results are highly suspicious for clinically significant prostate cancer should undergo prostate biopsy. And then biopsy, so biopsy established the diagnosis definitely. Technique include 12 core sample guided by transrectal ultrasonography. So we have to take different sample with a guide of ultrasound, MRI targeted biopsy, or both combined. We can use both. False negative result often occur, so multiple biopsy may be needed for prostate cancer to be detected. Okay. So what our approach for management or treatment in case of we have a prostate cancer? Current guideline on localized prostate cancer from the American Urological Association and American Society of Radiation Oncology and Society of Urology Oncology strongly recommend that selection of management strategy incorporate shared decision-making and explicitly consider the following. So there are certain things we should consider in patients before we start treatment. So first, we should consider cancer severity, the risk category. This is depend on the staging and of the cancer and other things, and patient symptoms, maybe presentation, patient value and preference. If this treatment gonna affect the patient quality of life, what the patient prefer, life expectancy. If this patient also like the 10-year survival and the age of patient and this kind of stuff, and pre-treatment general functional and genitourinary symptoms if the patient having any symptoms, and expected post-treatment functional status. So if this is, as we said, gonna affect this patient. Sorry, 1 second. So if the patient is having localized prostate cancer, so the standard treatment for clinically localized prostate cancer include watchful waiting and active surveillance, radical prostatectomy or radiation therapy. And there are certain emerging treatments with limited long-term data include some of them like targeted therapy and whole gland ablation. And so active surveillance, this is just like we do like continuously prostate-specific antigen for monitoring. We can do also several confirmatory prostatic biopsy and repeat prostate biopsy at predetermined time or point, or like we can send the patient and say you, at least you have to come after 12 to 24 months to repeat the biopsy. Definitive local therapy, we can use like definitive local therapy for prostate cancer generally involve either like surgical removal, or we can use radiation of the prostate with or without removal of or irradiation of the draining pelvic lymph node. So it could include lymph node removal or not. Surgical therapy for prostate cancer involves the removal of prostate and seminal vesicle and the draining pelvic lymph node when risk indicates removal. With re-anastomosis of the bladder with the urethra. Historically, prostatectomy has been performed by an open surgical approach, including perineal, suprapubic approach, or retropubic, and infrapubic or transrectal, or ischial rectal and sacral. Over time, however, radical retropubic prostatectomy became the gold standard for prostate cancer surgery, and those other approaches were largely abandoned. So mainly now the gold standard is retropubic. For radiation therapy, it offers potential for curative treatment of localized prostate cancer. It may also it may be delivered as external beam radiation therapy or brachytherapy, which is through insertion of radioactive seed into the prostate gland. So external beam radiation therapy technique includes three-dimensional conformal radiation therapy and the intensity modulated radiation therapy with hyperfractionation, radiation therapy plus androgen therapy. That's another sort of treatment. We can use radiation therapy and androgen therapy. Radiation therapy as an adjuvant or salvage therapy after surgery. So we can use both surgical removal and then radiation therapy. There are some, as we said, emerging therapies. Several emerging therapy for management of localized prostate cancer are gaining traction, though they are not yet routinely recommended for that purpose. So one of them is a whole hemi or partial gland ablation or ablative therapy, such as using cryoablation or high-intensity focused ultrasound and photodynamic therapy. So they are generally utilized in patients with low risk for prostate cancer, and their long-term safety and efficacy data is still largely elusive. So these are still emerging therapy. Okay, so in case of non-localized or recurrent prostate cancer, so definitely prostate cancer may recur in up to a third of men after definitive local therapy. So this disease state is now subdivided into castrate sensitive or castrate resistant locally recurrent prostate cancer, castrate sensitive or castrate resistant metastatic prostate cancer. So it depends. These disease states are rarely curable, but recent advance in the understanding of salvage radiation therapy, chemohormonal therapy, and androgen blockade, or even poly-ADP ribose polymerase PARP inhibition has greatly prolonged survival of these men. For full discussion of this, I'm sorry, I think this is just other information. So in case of management of advanced metastatic disease, so again, American Urologic Association guideline on advanced prostate cancer separate management consideration into the following 4 disease states, which encompass their entire continuum of advanced prostate cancer. So biochemical recurrence without metastatic disease after exhaustion of local treatment option, or metastatic hormone-sensitive prostate cancer, non-metastatic castration-resistant prostate cancer, metastatic castration-resistant prostate cancer. So these disease states are defined by the following. So the primary tumor status, presence or absence of distant disease on imaging, if there is metastatic versus non-metastatic, and testosterone level, so non-castrate versus castrate, and prior chemotherapy exposure. So this is depending on if you have a localized or advanced prostate cancer, and then treatment, if you would like to give treatment with curative intent, so no relapse or not suitable for curative treatment, so it depends. So in case of patient suitable for curative treatment, we can start with biochemical. So if there is biochemical relapse, rising prostate-specific antigen, we go for observation. Patient with metastatic, we can use medication, Apritron or docetaxel. So again, it depends on if there is a metastasis, or if we are intending to cure, or it's just not curable disease. Okay, I believe this is the end of the presentation. Thank you, Dr. Dalia, for preparing this, and thank you, Dr. Nadir, for giving me opportunity to present it for all of you. If anyone have a question, please.
Thank you, Dr. Samia.
Thank you, Mayra.
Dr. Nadir, on the next topic, there was a miscommunication with the team. The doctors that they are on the presentation, they are not part of our group. Dr. Anna, she's on the red team, and Dr. Ashwini, she's from the yellow team. And they are not in the Lyme group, and I didn't realize they were not. I apologize, and I can present that topic next week if you allow me to. But they are not part of our group.
That's fine. I think I made a mistake. I think I put the names when I copied the topic title from previously. They presented last year. So,
oh, okay. I was like, they're not.
Yeah.
Like, yeah, we didn't realize, and I have been like so focused in studying that I didn't even like notice.
No worries. Thank you so much, Dr. Mayra, and thank you, Dr. Samia, for great presentation. Thank you. Excellent. So for the topic, geriatric syndromes, we don't have to delve into the details. I just want you to know in geriatrics, like in pediatrics, we have some syndromes. So, for example, falls is one thing that happens as we get older. So our goal is to understand why we get one of these syndromes as we get older, or when we treat our patients, and how to prevent them from happening. Let's say we were just talking about prostate and enlargement and so forth. So if there is a way to screen and treat before the patient has significant symptoms and end up going to surgery, that might be an option that we can look at as we work like family doctor, internal medicine, or primary care provider. So our job is to make sure as the population age, as your patient age, you want to prevent as much from bad things happening to them. So falls is a major problem as we get older, because sometimes it may be a sign of infection or pain that's not controlled, or prostate enlargement. They want to go to the bathroom more frequently at night, And if the room is dark, they can't see what's on the floor, they trip and fall, and this might end up with some injuries, maybe fractures. And if this happens in older frail male or female, and the patient may end up, instead of walking, now they will be wheelchair bound. And if they are wheelchair bound, it may lead to some weakness of their legs that may lead to the patient needs more assistance. So instead of them being independent, doing things for themselves, including transferring and ambulation, now they are wheelchair bound. They are not able to stand on their own. They need someone to help them get out of their wheelchair to the bed, or from the bed to the wheelchair. So if we can understand the syndrome, and if we can understand how we can screen and prevent this syndrome from happening or from exacerbating, maybe we can help the patients. So this is the idea of the topic. So we don't have to go over it today, but maybe in the future we can discuss more detail. But these are great presentations so far. Thank you so much for all the presenters. Any other topics that you want to discuss? Okay, maybe we can jump to the last topic of the agenda item in the project updates. And do you have any updates? I know last week Dr. Naud presented, and the week before the other team presented in Vancouver. Anyone of the teams can share with us their experience? I don't know if you are available.
Yes, I'm available.
Yeah.
Can you hear me?
Sure. Yeah.
Yeah.
Go ahead.
Hi, everyone. I attended a conference called the North American Primary Care Research Group, which was held in San Francisco from October 31 to November 3. The conference was focused on primary care. And lucky enough, we had a systematic review paper that me and my team did. And it was provisional accepted the Annals of Family Medicine as a systematic review. And we ended up doing a poster for the North American Primary Care Research Group in San Francisco. So the conference focused one on the medical aspect, two poster presentation, and third one was papers or speakers which did research based papers, and the last one was also a way of connecting with other people. So my experience was one on the poster, and secondly on the conference as a whole, and thirdly on how we can benefit or how we can integrate what I have learned from that meeting to this group. So on the poster aspect, usually the poster session lasts about 1 hour and 1 hour and a half, and you put your poster, and usually there are two kinds of audience who have no clue on what you have prepared, and audience who are an expert on what you have prepared. So if you feel that from the questions they raise, or if they ask you, give me a brief explanation of what you have done, you don't need to go into detail or burn your energy, just give them a 2 or 3 minute summary. But if you end up being asked a question by experts or people who have done research on that, try to be more analytical and try to explain as much as you can and give a detailed explanation of your paper. And I wish I had someone from this group who also prepared a poster in that session. So on the poster part, my advice is all other people who are doing systematic review or paper who will eventually try to present it as a poster, try to connect with other people from this group so that you will submit the poster to the same conference. Because what I have seen was students or fellows or residents from one institution, they come with 4 or 5 posters and they end up doing it in one straight shelf, so that it will be more attractive and you will connect with a lot of people. And also you will feel more comfortable, you feel at home. So for those of you, I think last time, if I am clear or if I do remember, Dr. Iman and Dr. Ryan were preparing a poster. So it would be nice if you present it to the same conference. And for those of you who are in the verge of preparing a poster, try to connect with each other and try to submit it to the same conference. This is on the poster side. And on the presentation and the paper side, what really amazed me and really shocked me was like the amount of papers and the amount of time that was spent on AI, ChatGPT, and machine learning with integration of medicine. Because in this group, what we usually do is the first 1 or 2 sector is purely medicine based, and the third and fourth part of the presentation is more into computers and stuff. So from the looks of it, this chat GPT, AI, and machine learning will eventually be integrated into the medical industry. So we will reach the point where basic computer skill may not be enough for a doctor. So I strongly urge that we include more and more the AI, the machine, the other aspects of AI-related topics with medicine to be more integrated in this group, and also to familiarize ourselves with any form of computer-related topics which will eventually be integrated into medicine. And the third aspect of the meeting was how to connect with people. So eventually you need to make a good connection with people, either for research purposes or eventually you may also make few connections who might help you in residency this year or the next year. Try to talk as much as you can, try to sell your ideas, try to sell what have you done, and try to be confident and try to be as much as you can to be more talkative. So that was my experience in the conference that I attended in San Francisco. Thank you.
Thank you so much, Dr. Nawaz. And Dr. Nawaz also presented the poster and shared some of his conference posts, shared this with Dr. Nawaz. And so he presented the post there. And thank you to Dr. Nawaz and his team. This is a great presentation, and thank you for sharing your experience there. So hopefully all of you can participate in some projects in the future and can present. As far as this conference, the next time it will be presented in Canada. That will be next November 2024. So we can plan ahead to participate in that conference. It's mainly for primary care, but you can, as Dr. Nawaz mentioned, you can make connections with this group. Sometimes you might have program directors or people who can decide in the residency program. So in any case, the more connection you can make, the better your chances will be. Thank you so much, Dr. Nawaz. Excellent work.
I also would like to thank my team because Dr. Asma was supposed to do this part, but unfortunately for medical reasons, she was not able to do. So Dr. Asma, Dr. Samia, Ryan, and for you, of course, and Dr. Dua and Nasreddin were very helpful in the initial preparing of the paper. So I would also like to thank my team members. So thank you very much, Dr. Nadi. I really appreciate it.
Thank you. And again, thank you and your team. Great work. So Dr. Ryan, if you are there, I think you and your team also presented in Vancouver. Or anyone of that team. So that was for the international also conference on gastroenterology, and that was presented in Canada. So there is a poster also was launched and presented, which is good. I don't think that was with us today. Any updates as far as other groups or other projects?
And may I add something, Dr. Nadir?
Yes, yes.
You can also do what I call before you attend the meeting or whatever conference or research or abstract submission that you want to attend. The one thing that I didn't do, but I wish I did, was 2 weeks or 3 weeks ahead, try to post it in your social, especially on LinkedIn or ResearchGate or on Twitter, that you are attending in that meeting. So you might end up having people with within your connection that you haven't known before, but they may end up attending. So try to advertise that you will attend that meeting, so you will be at home, or you will feel like more connected when you do the 3 or 4 day, because at the end of the day, even though you are there to present a paper, you need some people to chat, to have tea, to have coffee. So to be very more organized for you. And last advice is try to plan ahead, because usually the conferences are held out of your state. So the ticket prices, the hotel prices will be cheaper for you if you plan 2 months or 1 month ahead. Thank you.
Thank you so much, Dr. This great tips also. Did you use the handout? Printed?
The funny thing about handout was most of them were not interested in the handout. The one thing that I didn't do, but I wish I did, was most of them have like a small business card print out, a hard copy, where they have their contacts, their LinkedIn account or ResearchGate account, so that they will hand them directly. So nobody was interested on the handout, but lucky enough, I had a barcode in my poster, so it was good enough for me.
So the barcode can work as a business card. So most of the people who know how to do it, they can just print or scan the code, and they can get your information on their phones, and then they can contact you in that connection.
Yeah, but I cannot stress enough about how heavy the concept of AI, ChatGPT, machine learning, and medicine were. Because I always thought when I was attending this session, I was more focused on the first and third aspect of our Saturday meeting. But in every session, at least maybe 50 or 60% of the session that I attended, they were heavily discussed, and even the resident, the medical student, were aware on what the evolving future would look like. For example, they were talking about history taking, vital sign taking, and note rearrangement and emergency note rearrangement using AI and other stuff. So this was a bit new for me. I always thought that we should focus more on the medical aspect. So this way or that way, I think it's good if have an idea or at least a familiarization with these basic concepts.
Yeah. You're right. So we need to focus on that. So down the road, if anyone you have some ideas about new projects, questions, research questions, so we can work together, presentations, and sharing information about how we can use AI here in this program, and also in the future for your residency, fellowship, or even for teaching medical students or teaching others, like the public about certain major topics or important topics. Yeah. Sounds good. Thanks for sharing, Dr. Mustafa. Go ahead.
Okay, assalamu alaikum everyone. Thank you so much for your efforts. Today's session was very, very informative. I am a new member, so I was asking if I could join teams or join future research projects, or if there are any ongoing projects that I can join or participate.
So we will contact you. So we are in the process of creating a new team, because we have new members. So we will create a new team, and we will assign one fellow to be the leader for that team, and then they will be in contact with you. As far as the projects, just to repeat what we do. So you can bring your own research ideas, research questions, You can be the leader if you bring that question, or you can join an ongoing process of project, and so you can be a team member for one of the projects. We have published work in the past as abstracts, so now we are in the process of converting this or some of these abstracts into papers. So if we go to the website, so if we go to this website, we have published almost 40 abstracts in the past few months, years. So we can assign you or someone to work on one of these abstracts. Let's say, for example, this. So it's a literature review, but it was presented as an abstract in one of the conferences. So we can elaborate and get more information about this abstract and the basics that the team is being collected the data, so we can build on top of it. So we can generate a manuscript out of this, and then submit that manuscript. We can change the title to something more recent or catchy, and then select what type of journal that can accept similar topics. You can create a team if you are the team leader, or you can join a team and you can work on that. So this is one idea of how we can get things going from what other members did in the past. So we have 40 options of abstracts. Any one of these abstracts can be converted into manuscript. So what you need to do is that you need to elaborate on the discussion part and the production part, and then revisit the data, see if there is any updated. So you can use the same method that was used and get the same data. Maybe you will have more articles listed, so you will add this into your results section, and then you can elaborate as far as what's the impact, what's the importance of this body, and how it can help people if there is any limitation, and what the future direction looks like, what other questions you will be asking to do further in that study. So this is one idea that can any one of you or group you can get together to start a team, work on one piece, abstract conversion intensive manuscript, and then we can talk about where we can stop with this manuscript.
Okay, thank you very much.
You're welcome. Anybody else? Anything else? Any other questions, any ideas, any suggestions? Okay, I need from you, anyone had interviews in the past, kind of share our experience. How did the interview go? Or if you have invitation, how is it going for you guys? So regarding this program, any suggestions, anything that you want us to do, maybe it can help you in your endeavor or in your approach to applying for residency, or we have a group of dentists, they are working also on some mastery of other products, maybe you can help them as well. So anything that you think we can do differently, or we can improve on, or we can help you with. I know Mayra started a group to teach some of you the basic Spanish language.
Yes, I started the group. It's a little bit on pause until I
Mhm.
present my exam, but once I present it, we will start again. Yeah, we have like 5 classes and it was so nice. I still have the recording for like class number 1, 2, 3, and 4. I can share it to you and to you guys, and you can see it. It is really, really fun. And
That's it.
it is, yeah. And then I will let you know when I'm starting. Probably in January. That we'll start new year and new classes.
Sounds good. Do we have the, can you share with me the recording when is the time? Thank you.
Of course, of course. De nada, Dr. Nadia, always to help.
Yes, yes. Thank you so much for your help. Again, we are also working on developing some apps and mobile applications. So if you are interested, you can reach out for some of the product leaders in this development project and see how you can contribute. I know most of you, they don't know the programming and we are not expecting you to know some coding or programming or how to develop an app, but your ideas of how we can improve things, how we can, from a user-friendly approach, can we make the app more user-friendly, or maybe you can select certain colors that might be user-friendly or attractive. Also, you can try trading or some of that. And so, we need some people to look at the app for some feedback. So if you have a good community, good connections, and your friends in the medical fields and you can join a team, and then you can connect with your friends talking about this mobile app. One way you can also share it on your platform, like Facebook, Twitter, LinkedIn, all this can help promote the app so that people can give us feedback and see if we can improve the best version when we are looking to develop the newer version and so on. I know some projects are in the idea process, so still the teams are working on collecting the information. Some already published and Google Play Store.
Yeah,
have
we.
three. Yeah,
Sorry to interrupt. In the pressure care app.
ahead.
No, and the pressure care app. Dr. Natifa, we just finished like few weeks ago in September. We finished the translation to Spanish. Because now you have the app translator. Yeah, we did the translation to Spanish with Dr. Wall and Dr. Dua, Natifa, and I, my person. We did a translation. So you have that app, Pressure Care, in English, Spanish, and I don't know if it's in Arabic as well. This,
I think there is a team working on Arabic version as well. Yeah.
I think they're working in the Arabic version, but yeah, you have it in 2 language. And if you guys, you can find it in Google app, and you can find the pressure care. I don't know if yet the Spanish version is released, but it is translated. So that's good news.
That's great news. Yeah, thank you for sharing. So again, as a fellow, you have the opportunity of participating is either as develop the app yourself or help in each task. So one task is translating into other languages. You can work with teams to make this app into more or more than one version, English plus other languages as well. So if you are fluent in your language, you have time, we can talk with the product leader, you can be the leader for that language and create a team just for translating that, and then you can add all this translated information to the app so that it can be available on the Google Play. For now, we are started in Google Play Store. In the future, we will get into Apple Store as well. So it's kind of a challenge for us to develop an app that can be used in iPhones for now. Dr. Ashansa, go ahead. Thank you.
Mhm. Thank you.
Hi, Dr. Nader. Firstly, thank you for your continuous support. So I have a question. I have like a case report. It's outside the fellowship. So I'm trying to submit it to Curious, but they're asking about the RAB. So I don't know how to do it. So I'm just asking.
So, my understanding, IRP is required for all the research products. Sometimes they waive this requirement, but they need to get the application to the IRP. And so what that includes is there is in each institution there is a committee where they look at these applications. Either they will say, yes, we can approve this application with no requirement for reviewing, so it's going to be waived, or it's going to be a shorter review, that's the fast one, expedite, when that doesn't take a long time, it can be approved, or it can go through the whole process of the approval, which is the review committee will look at all the documents, all the process of your project, and then if they have questions, they can ask to clarify things. And the idea of all this process is to prevent harm that can happen to your patient or number of patients or subjects or volunteers in your that include patients, volunteers, or even animals if you are difficult to that the RFP. So if you have a case, you can submit to the RFP via MSU and get approval or the waiver. Then you can put it in your submission that you apply the IRP to MSU, or you are working in other institutions that have IRP, you can go through the process through their your institution there. That's one way of doing it. I hope I answered your question.
Okay, thank you, Dr. Nader. Thank you.
You're welcome. So now there.
I don't know who the previous caller was. I think I may have communicated with one of your team members. I think it was Dr. Dua. So I currently am doing a part-time volunteering job for a journal as a peer reviewer. It's a clinical case report. Maybe you can connect me, because I think it will be easy for you if you have someone who's in the institution who can review for you, and it will be easier for you to submit. So you can connect. I mean, you can contact me, and maybe we can do something about it.
Okay, thank you, Dr. Nader. Thank you so much.
Excellent. Thank you both. So again, this fellowship is just an opportunity for everyone of how we can. So some of you have some knowledge in certain areas or skills, and some of you are new to that area or the skills they don't have it, so we can share and improve our level of empower each other. The idea is to find ways of improvement, and hopefully you can help others to improve while you are improving yourself. So, and you can mention that so in your application, in your interviews, that you are either developing these skills in this program or teaching these skills in this program. So either or, you are a learner or you are a teacher in this program. You will be able to mention that in your interviews and in your application. And hopefully you have been down the road as well. Thank you. Any other questions or any other ideas, suggestions? So can also you already shared in the Twitter, I think, or link it that you presented, but if you share it with other like research page or Facebook, that would be great. Also, again, would be great that any one of the team members can mention that in the social media platforms, anyone that you already present, and it's a good one. Excellent. So it's already in LinkedIn. And you can reach out to Dr. Doa and her team who presented in Vancouver a few weeks ago. So they can do the same. So any other questions before we end the meeting? If not, then I'd like to thank you so much, Dr. Mayra and your team, and I'd like to thank all the presenters on today.
Thank you.
Oh, Dr. Esra, go ahead.
Yeah, I'm sorry, I have one last question. I want to know, contacting is through email or through which channel?
You can reach me through email, yes.
I can reach to what?
You can reach me through emails.
Okay,
So I'm going to put my email just here.
okay, thank you so much.
So you have the email in the chat.
Thank you.
You're Thank you all for attending this meeting. Thank you, Dr. Mayra, for presenting and also leading your team and leading the Zoom meeting today. Thank you, everyone. Thanks to those who will come and look at the video later. Have a wonderful day and good night or evening, wherever you are here next week.
Thank you, Dr. Nadri. Have a wonderful day. I put on the chat
you.
both of the YouTube videos that they were good for Conrad and Padma, so you guys can check it.
Excellent. Thank you so much for sharing.
Thank you, sir.
Thank you.
Thank you so much, Dr. Nadia.
Thank you so much.
Thank you so much, Dr. Nadia and everyone.
Thank you, Dr. Nadia.
Thank you, Dr. Nadia.
Thank you, Dr. Nader.
you so much.